So, thank you, Mr. Chairman, ladies and gentlemen. First of all, I have to thank with my group Professor Inouye and Thomas Rösch and Daniel van Renteln in Hamburg, because there I had the opportunity to learn the POEM procedure, and Professor Inouye came to Hamburg and taught it to Thomas Rösch and Daniel van Renteln, and then they helped me in learning it in Frankfurt. And so far we have been doing this very safely, and I can just comment on the recent discussion about whether to use a balloon or anything. I think that the beauty and the safety of introducing this is due to the fact that we learned from Haru Inouye this really stepwise and extremely careful going on all down through the tunnel and performing the myotomy in a really careful way. I have seen from gastroenterology videos in Germany that are much more excited about this going down there, and I can just suggest that if you start, you really be careful and follow that stepwise procedure, because I think it's important. These are my disclosures, and I would like to open up for the European situation. That in Europe, of course, we have a different situation in different countries, and the penetration of flexible endoscopy in surgery can be very different. So endoscopic pneumatic dilatation is a very strong issue in Germany, and this has been until I think the early 2000s, because only then laparoscopic myotomy slowly came up on the market. So I think that was the start, and of course we had showed that laparoscopic myotomy can be a very safe and very successful operation, and you know the numbers from the publication of Campos. Another thing is we are not too excited about the new Chicago classification, especially the group 3 or stage 3 achalasia, in which we think a lot of the diffuse spasm patients are included in that. And looking at the data of the recent randomized trial, pneumatic dilatation, the European trial versus laparoscopic myotomy, shows that there is a worse outcome in the group 3, and I think that is due because these patients are sick also in their esophageal body, and I think therefore this is a great indication for POEM in the future. I don't have any data to back this up, but I'm very convinced that this will be maybe even a better indication than achalasia. So we need to work these patients prior to our therapy up, and to make sure what we have for a diagnosis, and then go on. And I would, in this case, I would definitely use a POEM, because I think due to the long myotomy, I can help the patient in several things. You know, this is the basis, laparoscopic myotomy, and this is the result of the randomized trial, which is surprising to us all who have experience in pneumatic dilatation and have experience in laparoscopic myotomy, because in this randomized trial in Europe, it shows that the results are quite similar. And I have no explanation. This is a randomized trial, so I have to take the result, but my experience over now 30 years of dilatation and myotomy shows me that myotomy is, you know, has better advances. So now we learned this new technique of peroral transesophageal myotomy, and again I would emphasize the point to do this very carefully. It doesn't matter whether you use 50 minutes or 150 minutes in the beginning, you just have to make it safe, because obviously from the numbers that you have seen here, it is a safe operation. This is the way it was introduced in Europe. You know, you see a group of us trained on the pig model. The first case in Europe was done in Hamburg with Thomas Rösch, Daniel van Renteln, and Haru Inouye. And then we did in Frankfurt RB application and got approval a few months later, and then started. And we are included in a multi-center trial. Most of this are Hamburg, Frankfurt, Amsterdam, and Zurich are the European centers, and Montreal in Canada. And there is a randomized trial in planning. And I think I don't go over the details again of, you have seen this in a wonderful way, so I skip this. I just want to show you after 6 months later, the esophagus and the healing of the incision, which is quite nice, and there is no problem in having any further dysphagia or anything. When I was in the US last summer, we did an estimation of the patients that were done so far throughout the world in the NOSCAR group. We could see that Asia was aiming for 140 patients, and now if you look at Europe now, you can see that it's similar as the US. It's around 100 cases, and those are the cases that I could track down and through phone calls look at it. I don't know what's going on in other centers that might not report or are not involved in any of these organizations and follow-up studies, and especially I have no idea what's going on in Eastern Europe with the reports of what is happening there. But from what I hear from these cases here that have reported, it is a very safe introduction. Just to put the POEM experience in perspective, we have done 12 in Frankfurt, and you hardly can find in Germany a patient with a primary achalasia that hasn't gone through the hands of a gastroenterologist, who hasn't done any Botox or EPD before sending it on to a center. So most of the patients have some previous therapy done. And indeed, it is quite difficult if you have several Botox injections, especially deep Botox injections, then also the circular and the longitudinal muscle can be stuck together. On the other hand, I must say, I don't think this is a big problem, because as surgeons, we're used to cutting the whole muscle layer, and then we are in the mediastinum, and so far I haven't seen any big problem with this. Looking at the data, you can see that, and that is something to think about and worry about. One is we had 2 emphysemas that were extensive, and that I think is due to very difficult cardiac dissection, so it took some time, CO2 insufflation over a longer time, and that took care of inflating the CO2 into the retroperitoneum, even going down, and so that can be a problem. The patients didn't have any damage with this. We just had to take them a little longer in the hospital because their faces were swollen up, and also their body had this emphysema. Looking at the Eckhart score, I will come to this in a minute to some more. Looking at reflux, again, when we have followed up our 12 patients, 10 we have followed up, 1 had a clinical reflux, and we measured 8 with pH monitoring and have seen that 3 of these 8 had documented pathologic acid exposure. So there will be a question in the future, is this really a problem, or is it not a big clinical problem? Looking at the procedural time, this is the curve. You can see we are hanging around in the area of 100 minutes about. The red is Hamburg. We have now 50 cases, and we have 12. So that's about the level of time. Again, I would tell you that I don't try to speed this up. I just go step by step down. Looking here at the quality of life pre and postoperative, you can see that it's an improvement of the quality of life. This is the improvement of the Eckhart score in our Frankfurt 12 patients, and this is the improvement as published by Daniel van Renteln in the American Journal of Gastroenterology with the Eckhart score from the patients in Hamburg. So POEM in Europe, roughly 115 patients are done. Complications so far, minor. There is 1 hematoma reported from Switzerland. We judge among us that the recurrency rate will be probably somewhere between 5 and 10%, but we don't know this data yet. And reflux, we would judge now probably around 10 to 15%, and I think it's not a big problem in adding a partial fundoplication later if this is really a big clinical problem in a patient. Again, from Eastern Europe, I don't know the data. So And just a little hint, in Europe we have the EAS meeting in Brussels and in Prague the Euronotes meeting. Thank you very much.
Questions for Professor Fuchs? So you mentioned the emphysema as a complication. Often we do, and we had a debate of whether we should publish that as a complication or not. I mean, it happens in laparoscopic surgery all the time. We don't typically have it as a complication.
I agree, and I think we have to make also differentiation. If you have the end of the procedure, you know, some emphysema up here, it's not even worth to talk about. That's just thing. If the emphysema goes, you know, throughout the body, through the retroperitoneum, then you know, the patient has a certain discomfort, and these are these two patients that took them for some time in the hospital.
What do you think? I'm sure you've encountered often the longitudinal layer is very thin and separate, and often you're looking at the vagus nerve or the pericardium. We elected not to call that a complication either. It just seems like a physiologic variation that some patients have a discontinuous.
Personally, I was surprised that the longitudinal muscle, and having had a couple of thousand esophagi in my hands over the last 20, 30 years, I was surprised how thin this is looking from the inside. And still, I think it's not a big problem. And I know if that recurrence rate that we judge with maybe 10%, if we could improve that by cutting the whole layer, I would not hesitate to do that, because it wouldn't be a problem, because we are in that layer when we do laparoscopic myotomy anyway. So the only thing would be then the emphysema would probably go up a little, but that's also not a problem.
Haru, what do you think about? Do you do anything special if you go full thickness through the longitudinal layer? If it's just split and you're there, do you worry about that or just ignore it?
No worry about it. No worry about it. But when we totally dissect the muscle layer at the time, so we control the insufflation volume. So we keep less and less insufflation. So of course we use a CO2, but we control the volume less and less. Over there.
Yes.
Joe Peatland from Kansas City. A comment was made earlier about checking for candidiasis. And I may have missed the discussion about it, but could you all address that?
Yeah, I mean, we try to have the esophagus clean, and so in our 12 patients, we made sure that the esophagus is clean. And if we were not sure, we hadn't seen the patient before, we would scope him like the day of admittance to check out, how the esophagus looks, and we would even withdraw the case if we would have a full esophagus and a candida infection.
Yeah, and likewise, we postponed our case, brought them back a couple days later when we found bad candidiasis, and now we pre-treat everybody. We put everybody on nystatin for 5 days.
For what, 5 days?
Mm-hmm. Joe, on the other hand, Professor Inouye says that he doesn't pay any attention to it, just washes it out. But yes, Andrew.
Do you guys ever foresee doing this without a general anesthetic? Or have you done it without a general?
No, I would not.
Are you tempted ever to do it under sedation?
Never. Never, but I think very dangerous, because without intubation, so our pressure of the mediastinum is totally become negative respiration may cause a huge pneumomediastinum. So I don't think it's better.
Do you give to the patients any kind of antibiotics as a prophylactic manner?
Yes.
Mm-hmm.
Yes.
What do you?
One shot cephalosporin in every case.
even if the patient gets perforated, you just one shot?
Well, so far I had no perforations, and that's a different scenario. And then I would, he gets one shot, that's the protocol. And if I would have a perforation, I would try to close it. I would use clips at the spot where it is and close it.
Yeah, I'm a little bit of concern because I have been seeing that we are talking about a lot of patients with high-resolution manometry. And as a personal manner, I think the high-resolution manometry is like a little bit more about being more comfortable seeing the colorimetry things. And I want to ask Dr. Inoue if his patients has high-resolution manometry, or could be also if he has seen different results with just regular manometry in the outcomes.
Do you use high-resolution manometry?
No, fortunately, in Japan, we cannot yet buy the high-resolution manometry. I'm sorry.
I will make a comment that nobody mentioned the use of a high-definition endoscope, which you taught me is very important.
Yes,
high-definition endoscope.
High-resolution endoscopy would be better. Because we can watch carefully the bundle of the muscle.
Professor Inoue or anyone else who has had an experience with this, I wonder, we had one of our patients that was very, very difficult. And I feel like there's certain aspects about certain patients that may allow us to predict whether or not they might be good candidates for this procedure. And in particular, this patient had very granular looking mucosa, dilated esophagus, and in particular what made it challenging was not only creating the tunnel and so on, and he hadn't had previous Botox or anything, but was also closing the mucosotomy at the end where it was just not as pliable or as workable as you usually expect it to be, like a normal kind of mucosa. And I could kind of tell at the beginning of the case, it sort of made me think that maybe this patient might be challenging, but I wonder if you have any experience with that or if there's certain predictors for you that make you think that some patients might be more or less appropriate for this.
Just talking about when the mucosa looks like the elephant skin, real thick and knobby mucosa.
Yes, in a long-standing achalasia patient, so sometimes has a very thick mucosa, but we can do it. But at the time, so it's better. It's better.
We did do it, but it made me sweat.
It's better to use a Boston clip. Usual cases, Olympus clip is very nice to close the mucosa, but in a very thick mucosa and a dilated esophagus at the time, so Boston clip is more strong. So, like that. But only in my experience, not in my hospital, but I experienced only one case that was a terminal achalasia patient. So very thick mucosa, dilated, tertiary inflammation. So in that case, it's impossible to create the submucosal tunnel.
And we found that those patients are especially difficult because, interesting enough, if the mucosa is thick, the muscle layer is paper thin.
Yes.
And so there's a correlation with that. The ideal ones are a narrow esophagus with a thin mucosa, which sometimes tears, and so you have to clip it more, but they have a nice, robust, thick, circular muscle layer. Yeah. So I think there is an inverse correlation.
Two questions for the panel, and I think this is very exciting, the work you guys are doing. One, has any of you converted a POEM procedure later for failure to a laparoscopic approach, and how difficult was it to separate the mucosa in those cases? And secondly, have you found any difference in the age of the patients? When I do it laparoscopically, I find the older women, the muscles just spring apart when you just try to separate the muscles. Is it the same in POEM? Can you see the difference in the muscles depending on the age of the patient?
Are old patients different muscle for really old patients? Do you think there's a difference in the muscle layer? Yeah, thin muscle maybe, or?
So what you mean in the old patient has a different muscle structure.
I mean, I find the muscles, you just touch them and the muscles tend to spread apart, especially older women. In 70 or 80, if you do the laparoscopic myotomy, you touch the muscles and tend to, it's very easy to tear them apart. Do you find it the same in the poem? The thickness of the muscle changes?
Yes, so very old patients, usually everything very fragile.
Very fragile.
So muscle layer is also sometimes split each other.
Yeah, I would agree with that.
I feel also that, you know, I have some patients where it just moves apart. You can just, you know, do your coagulation, spray coagulation, and boom, the muscle goes nicely apart, no big problem. And others, you have to pull a little more. And about the laparoscopic, I will have 2 patients scheduled next month of recurrency. Then I can tell you then.
From your poem patients?
Poem patients, yes.
Wow.
So we'll see how that goes.
Eric, what experience did you have when you reoperated on that one patient you described?
Remarkably, the mediastinal dissection was not too bad. There was evidence of some kind of mild mediastinitis up in the chest when we were mobilizing the distal esophagus. You know, we've tried to orient our poem myotomy again more on the lesser curve side, so we erred on the more side of the on the greater curve, a little more anterior greater curve, and really didn't have a problem developing the plane. We're able to do the myotomy without difficulty, actually.
And how long after the poem procedure was?
It was 3 months.
3 months after. Okay. Thank you. I think our period is up. For time, I thank the speakers, I thank the chairman and Professor Inouye and all of you for attending. Thank you.
Thank you, Ben.